So let's wait for 2 minutes only. If no one else turns up, we'll start. Only if in case this Zoom meeting gets over, I know time, कहिलेको आधा घण्टामा पनि warning दिइदिन्छ. If that happens, please come back with the same link, right?
Ma'am, we
can start. No one else will come. Can you see the screen?
Yes, ma'am.
And you can hear me fine, eh?
Yes, ma'am.
I'm in the department and the internet isn't too stable and reliable. In case त्यस्तै केही पर्यो भने we'll have to rejoin, हैन? Yeah, internet problem. In case if that happens, I'll message in the Viber group. No, होला भनेको, just a warning. And if this lecture gets the Zoom gets disconnected before the lecture gets over, we'll come back again. We'll try to finish in another 35 to 40 minutes. है त वैभव पनि आयो. Okay, so we'll start. So today we'll be talking about meconium aspiration. So in meconium aspiration, as a तिमीहरुको password थियो नि, what does that stand for? आज यो meeting को password के थियो भन त? MSAF हैन? Can anyone tell me what that stands for? तिमीहरु सानो batch भएकोले we can interact. MSAF के हो? Anybody? थाहा भएन? यो topic meconium भनेपछि obviously M stands for meconium.
Ma'am, meconium stand amniotic fluid.
आउने भन त, who was the last who came? भर्खर को आएको थियो? वैभव, do you know what MSAF stands for? तिम्रो unmute पनि नहुने? Oh, you can't hear me, के हो? Archana, can you hear me?
Yes, ma'am.
ए नबोलेको हो वैभवहरु.
Yes, ma'am.
ल, that's fine. It's okay. So MSAF stands for meconium stained amniotic fluid. Okay, meconium stained amniotic fluid. So all of you know that meconium is not supposed to be passed while the baby is still inside the mother's womb. I know. So there are certain mechanisms which prevent the baby from passing stool inside the amniotic fluid. But sometimes when there is increased stress on the baby, which we call it as fetal distress. So this the fetal distress. So that's why we see that babies pass stool in the amniotic fluid, which can lead to a lot of other complications. So if that stain liker, meconium bhayeko amniotic fluid, if it in case goes inside the baby's lungs, then we call it as meconium aspiration syndrome. Okay, MAS. MAS has a lot of complications. So mild MAS हुन सक्छ, moderate, severe. So this can lead to a lot of complication and can even kill a baby. Okay, so we want to prevent this from happening. So even if there's meconium stained amniotic fluid, we try to prevent the baby from aspirating it. Okay, so as you can see, it's one of the most important causes of respiratory distress in newborn. But compared to before, meconium aspiration has become much less common because most of the deliveries are in a hospital, and during the delivery, good monitoring from the obstetrician side will prevent fetal distress. And even if there is fetal distress and there is meconium, if there is a competent pediatrician attending the delivery, then meconium aspiration can be prevented. Okay, तर कहिलेकाहीँ even in spite of, if meconium aspiration does happen, even if the hospital has good NICU, it is sometimes very difficult to treat the child. Okay, so once MAS happens, it's difficult. That's why we want to prevent it from happening. So I'm sorry if you've just had lunch, but this we have to see how the meconium looks like. So the first couple of days, a newborn passes this type of stool, okay, which is called as meconium. So as you can see in the picture, it is very sticky, dark colored stool. Okay, this is meconium, and first धेरै जसो बेबिजहरूको first 3 days यस्तो stool आउँछ अनि त्यसपछि it starts having bile pigments and yellow हुन थाल्छ. Okay, so what does meconium consist? Meconium is actually a sterile substance. Okay, and it contains as high as 75% of water and other proteins. It can also contain certain things that the baby has swallowed during the fetal life. Okay, the vernix that the baby sheds inside the amniotic fluid, even the lanugo which gets shed, and some debris. All this the baby swallows, and it's part of the meconium. It also contains bile pigment. Even in this picture, you can see that the one which is kind of spread in the diaper, you can see a greenish yellowish green tinge to it. So this is the color because of the presence of bile pigments. And it also contains secretion from the intestine, like in any other type of stool. Okay, so you have to remember meconium is sterile. So about 10 to 15% of live births can be complicated with MSAF, and out of this, only about 5% develop meconium aspiration. So you need to know that if it's only meconium stained and the child has not aspirated, it is not MAS. Okay, so MAS is only once the meconium goes into the lungs of the baby. If the baby happens to take a deep breath, the babies take their first breath, and if the respiratory tract is covered with meconium, then there is high chances of that getting aspirated. Okay. So this is the pathogenesis of meconium stained amniotic fluid. This usually happens in babies who are post-term. Okay, preterm it's very unusual to get meconium in the amniotic fluid. So usually post-term babies are the ones prone to develop this. And this, the passage of meconium is prevented. Ramanand भर्खर आउँदैछ एकछिन है, I'll add. So there are certain mechanisms which prevent the meconium from being passed into the amniotic fluid during the fetal life. So these factors are there. First of all, to start with, there is no intestinal peristalsis while the baby is inside the womb. This is directly affected by the low mortalin levels in the body. and the anal sphincter is tightly contracted. Okay, there is contraction. That's why for the meconium to pass, that has to be lax, which is prevented while in the fetal life. And there is something known as a terminal cap or a plug, which prevents the passage of the meconium. Okay, so once the baby is out, then only the peristalsis starts because of the mottling level goes up. The anal sphincter becomes more relaxed, and the cap gets repelled, okay, from the anal sphincter, and then the meconium starts coming out. So all this is normally to be happened only after the baby is born. So unfortunately, if something goes wrong inside the uterus, for example, if there's vagal stimulation due to the compression of the cord, or there's any other factors in the mother leading to fetal distress like PIH. So all these factors inside the uterus can cause hypoxia and acidosis, which in turn causes the anal sphincter to relax and thus passage of meconium. Okay, so this is the pathogenesis, how meconium is prevented, and the mechanism of how, when there is hypoxia, the babies tend to pass meconium into the fluid. So some of the other risk factors, as we said, maternal hypertension, diabetes mellitus, post-dated, post-term pregnancy, if the mother is a heavy smoker, other diseases in the mother unrelated to pregnancy, like suppose she is already a case of some respiratory disease or she has a cardiac condition in the mom, then that can also be a contributing factor to fetal distress. Hypertension, if it gets into complications and goes into eclampsia, preeclampsia, all these can lead to fetal distress and thus meconium stained amniotic fluid. Okay. Other factors, not necessarily maternal, like suppose there is IUGR in the baby, that can also lead to meconium stain liquor. Okay. So we don't really know that why the meconium stained liquor is aspirated. Sometimes even before the delivery, there's no explanation as such. But once the baby is out, when the baby takes the first breath, then if there is presence of meconium in the mouth or the upper respiratory tract, then that goes into the lungs. Okay, but we can't really predict which are the babies who might end up with meconium aspiration and which are the ones that will not aspirate. So as a pediatrician or a doctor attending the delivery, whenever we see meconium inside the mouth, the first thing we do is suction. Okay, clear it before the baby takes vigorous breaths and that meconium goes inside. Poila, they used to do ET suction also. Like if you see if there's thick meconium. So what you need to understand is meconium can also be of various consistency in the amniotic fluid. Okay, depending on how long the fetal distress has been going on. So suppose the fetal distress is relatively early and the meconium has just been passed and very little in amount, then that means that there is very thin meconium present and the amount is also less. But if the distress has been going on for quite some time, then the passage of meconium quantity is also more. Consistency also is thicker. So whenever there's thick meconium, it can actually mechanically block the respiratory tract of the baby. Okay, so sometimes even endotracheal intubation is done, and meconium is suction is done through the endotracheal tube to remove the meconium. Okay, so all that can happen, and we need to anticipate whenever the obstetrician informs us that the liquor is meconium stained. Some of the other things that you need to know is whenever there is chronic fetal hypoxia and acidosis, that may lead to the fetus, gasping even before the first breath, which in turn contributes to the aspiration of meconium. Okay, so once the meconium is inside the lungs, then there are a lot of things that go wrong. First of all, because of the nature of the meconium itself, there can be mechanical obstruction, like how you have in foreign body aspiration. So similarly, meconium will be plugging, obstructing the large as well as smaller airways. Okay. So even if the meconium is thin and it goes inside the lung, it can cause chemical pneumonitis. Like suppose in an older child, if the child aspirates vomitus, then there's a lot of reaction, right? So similarly, even with meconium, you can see that kind of picture in the lung. It can also lead to vasoconstriction of pulmonary vessels, which can later lead to pulmonary hypertension. Okay, and meconium also is known to cause inactivation of the surfactant, which again leads to hypoxia and respiratory distress. And it can trigger a lot of reaction, cascade of reaction in the complement system and increase the inflammation. That's why causing lung damage. Okay, so whenever there's whenever there's obstruction of the airways, like in any other foreign body, the mechanism is similar. So, since the meconium is thick and viscous, then it can lead to partial as well as complete airway obstruction. So, when there is partial airway obstruction, like how you have ball and valve, um, with that mechanism, you can have lower airway can either inflate or deflate. So if it becomes flat, then it leads to atelectasis. Otherwise, sometimes it can even lead to pneumothorax. Okay, because of the air trapping. Am I going a bit fast, or you are able to follow? So all this is given in your OP guide, and it's more than enough for you to be able to write an answer short note on meconium aspiration. Sometimes it can also be a problem-based question, like how you have your section C, where a scenario is given and you need to answer based on the scenario. So you might be asked meconium aspiration syndrome in that case setting. Okay. And there might be ventilation perfusion mismatch because of the obstruction. So meconium can also cause, as we already said, because of the pulmonary vessel constriction, it can lead to PPHN. PPHN stands for primary pulmonary hypertension. Okay. We, as earlier said, pneumonitis, inactivation of surfactant, and activation of complements. So what are the clinical features that the baby develops? Obviously, there will be a history of meconium stained amniotic fluid, but whenever this goes into MAS, then the symptoms are that of respiratory distress. So meaning that the baby will be hypoxic, the oxygen level will be low, the baby will be grunting, the baby will have fast RR, respiratory rate will be high, so tachypneic, and can even have retractions, chest retractions, subcostal, lower intercostal retractions. Okay, so we can also diagnose based on the X-ray. So on the X-ray, because of the obstruction as well as pneumonitis, you can see similar to a case of pneumonia or even ARDS, you see multiple diffuse patchy infiltrates, which is usually asymmetrical. If the obstruction is bigger, then you will see areas of atelectasis and areas where there is distal hyperinflation. Okay, something like this. Okay, there is air trapping as well as expansion. Can you see the space between the ribs have increased? Usually in a newborn, all the ribs will be slanting slightly downwards with the gap is too much here in this particular x-ray. And you can see there are a lot of diffuse infiltrates here as well as here. So it will be bilateral because aspiration, whenever the meconium is aspirated, obviously it goes to both the sides, but it won't be symmetrical. If there are patchy areas here, there might be patchy areas on the opposite side. Depending on how much amount of meconium is aspirated, there may be areas of consolidation. So, as we said earlier, severity of meconium aspiration can be mild, moderate, or severe. This is very important. So, please remember this. I'll give you a minute to go through the slide. एकचोटि खर्र पढ त यो
less than 50% oxygen less than 48 hours. It requires more than 40% of oxygen for more than 48 hours. Normally, severe requires assisted ventilation for more than 48 hours or for assisted.
Okay, so as you can see, depending on the oxygen requirement for a certain period of time, the cutoff is 48 hours. So we describe the aspiration to be mild or to be severe. And as you can see in the last line, severe is usually associated with primary pulmonary hypertension. Oh, sorry, I called it as primary. PPHN stands for persistent pulmonary hypertension, not primary. Meconium aspiration, you get persistent pulmonary hypertension. So how do you manage meconium aspiration? Obviously, as far as possible, we want to prevent it. We don't want the baby to pass meconium at all in utero. So prevention is the key. Prevention can be done in the antepartum period, intrapartum, as well as postnatal. Okay, but once, if at all, so just to spend a little time on this slide, antenatal prevention can happen if pregnancy is well monitored. She has had the adequate amount of antenatal visits, and there's a birth plan. If there's any complication during the pregnancy, like hypertension or diabetes, all that is managed. Even if there's oligohydramnios, all that is addressed. So if the antenatal care is good, then we can anticipate when the delivery is expected. We will not let the delivery go up to post-term, right? So all that would prevent meconium aspiration, and even intrapartum, regular monitoring, every hourly monitoring of the fetal heart rate will be able to pick up fetal distress very early. So if that is picked up, we can prevent passage of meconium in the fluid. Postnatal, in the sense that baby is already born, we know there is meconium stained amniotic fluid, but we can anticipate and resuscitate very well so that aspiration doesn't happen. Suctioning, clearing of the airways, good resuscitation, administration of oxygen, all that can prevent the aspiration. Okay, but unfortunately, suppose if the aspiration has happened already, you are not able to prevent, then we have to give supportive care to the baby, starting from temperature regulation and making sure that the baby is hemodynamically stable, doing a certain we need to do the baseline investigations and address whatever the problem is. Suppose you do hematology and you find out that the hemoglobin is low, we can give a transfusion. Similarly, biochemistry mapani, if there's anything abnormal, we need to address those issues like maybe hyponatremia, hypocalcemia. So all that has to be taken care of. Infection has to be prevented. Though meconium is sterile, once it goes into the lungs and if you at all see consolidation, then we need to prevent secondary bacterial infection. Okay, as you know, newborn are very prone to develop infection because of their susceptibility and low immunity. So infection control is of importance. And whenever there is fetal distress, of course, there'll be associated asphyxia, which is again another problem and has to be managed. So respiratory management, most of the time, if it is mild meconium aspiration, only supplemental oxygen can um, treat the child with proper antibiotics and hemodynamic support. But if it's like how you saw how mild, moderate, and severe is divided, if the oxygen requirement is much more and going on for a prolonged period, sometimes the baby may even need support of CPAP or ventilatory support, okay, mechanical ventilation. Apart from respiratory support, even the ventilation, though it may not be feasible and available in our context, but high frequency ventilation is the ideal type of ventilation which is to be given in meconium aspiration babies. But most centers in Nepal, we don't have this. So, but of course, there are places where there are no ventilators at all. So something is better than nothing. But in advanced setup and Western countries, they do high frequency ventilation. Okay. And as we said, meconium can be a factor to deplete surfactant. Even in a term baby, if there's meconium aspiration, then the surfactant gets repressed or there's a deficiency. So one of the modalities in meconium aspiration, you will see that they try surfactant lavage, but it's very expensive and may not necessarily give a good outcome. So हाम्रो setting matter, we don't really practice surfactant lavage, but in countries where they can afford, they do try this. The treatment for persistent pulmonary hypertension is your inhaled nitrous oxide, and you can also give sildenafil. यहाँ लेखेको छैन. Please remember the drug of choice for PPHN is sildenafil. Steroid therapy voice. So steroid therapy is also can be tried, especially if there are features of ARDS. So these are the drugs that can be used. You don't need like ekdam detail meconium aspiration. All you need to know is what is it, what complications it can lead to, and what are the presenting features and your treatment modalities. Treatment map, please remember ventilation, oxygen support, respiratory support number one. This pachimate we will talk about drugs, and in case it goes into complications like PPHN, what will you use? Upi gaima ramrai dieko cha hai. So you can read from that today. But अहिलेको attendance actually quickly लिइहाल्छु ल. I've already gotten a warning of the meeting getting over soon. एउटा फोटो खिचिहाल्छु ल तिमीहरूको अटेन्डेन्सको. 1 second, don't leave एकछिन. तिमीहरू छ हैन कि निदायो? Anjali, you're there?
Yes, ma'am.
Archana,
Yes, ma'am.
Milan,
Train ma'am, yes ma'am.
Mohit. खै मोहित, Ramanand, Rishabh,
Yes, ma'am. Ma'am.
को बोलेर ल्याए? मोहित बोलेको.
Yes, ma'am.
Milan is here, no?
Yes ma'am, yes ma'am, I am here.
Ramanand खै त? अनि ऋषभ?
Yes, ma'am. I'm
सत्यधर?
here. Rishabh.
के रे? के भन्यो ऋषभ?
Yes, ma'am. I'm here.
Okay. Satyadharm, you're there? Ramanand,
Yes, ma'am. I'm
Natali,
here.
and Amandeep.